very often now because of the patients who have had multiple interventions before. We have a big group of patients who have had a lot of access from the femoral arteries, and sometimes it's not easy to get another access. For example, if the patient has 15 PCIs in 10 years, it's sometimes not easy to have an access through such a groin. Uh, the second the second reason for that is also that we need sometimes to go with the stream of the blood, antegrade. It's a good solution for the patients. For example, if you want to prepare them for syrup, uh, it's much easier to go with the flow in the iliac region and to open a CTO and then convert to the groin which is prepared. Because if you go up retrograde in the iliac lesions, it's very easy to make a dissection, which not happens when you go down. I don't know why, but that's the fact. Uh, so the first, if we need the access for example, carotid stenting, and the patient has iliac occlusion or not, it's not fit for iliac access, we can use radial or brachial approach. So it's a way to do things in the upper body. And the second reason, you can cross iliac region with the flow. So the first, very often made by our colleagues, interventional cardiologists, left or right radial approach. It's very simple, very effective, but of course have some drawbacks. The safety profile is excellent. You can use both hands to make a rendezvous, for example, in syrup. However, the diameter is small. You can use 5 or 6 French sheaths, sometimes 7, but it's risky. And you have very limited support and torque. So in chronic total occlusions, usually it doesn't work because of the lack of the support. Uh, Sometimes, of course, I will show in examples the tortuosity or any kind of problem if in access vessels, subclavian innominate can make it impossible. So this is the first example. The lady after TAVI, after multiple accesses to the groins, we could not pass from the groin. The second issue was the bovine arc. So we found out, and the intervention was because of the iatrogenic false aneurysm in the LSA. So we decided to go from the radial approach, from the right hand, and it was quite easy when you're catheterizing a left carotid artery. Uh, this is the second radial access to the male with also bovine arc and the issue in the left carotid artery. So it was easy way to go from from the right radial artery. I don't know how to play the movie because uh, can I can I get some help because there's a movie, the third and fourth. Okay. So the second option is the brachial artery access. It's of course when the radial arteries are too small or we need a longer distance because the distance is also limiting us. We can use brachial arteries. We use it usually under ultrasound guidance, and the equipment we can use is larger, so the diameters are 7 or 8 French. The advantage is strong pushability and um, much better support in the iliac region. So it's very useful when you cross the iliac occlusion. But sometimes we have issues, like at the first picture here, we tried to make renal artery stenting in that lady with severe hypertension, and we tried the left brachial approach, but we found out that brachial artery is occluded, but we had a pulse because of this collateral circulation. So we tried to first open the left subclavian, but we didn't succeed. So we used the right brachial approach, and then finally we finished the procedure. This is the second reason of brachial artery access and obesity. In obese patients, there is sometimes very hard to catheterize the vessels from the groin. There are two reasons. First, there are very often an infection there, and the second, there is a long way from the skin to the femoral artery. So we decided to use brachial approach in that case. It was, of course, reintervention. The lady has had restenosis in the stents in the iliac arteries. So we used the left brachial approach with the success. The limitations. Diameter, of course. Um, there is a higher complication risk than in radial approach because we have sometimes, I don't know, but it's more than 10% we have thrombosis of the brachial artery, usually because of the lumen of the sheath. The 7 French sheaths are more dangerous than 6 French sheaths. And if you use, for example, Advanta stents, cover stents to iliac region, we need 7 French. And mm, it's common, usually asymptomatic, but if we have no flow, we decide to reintervene, make an operation and thrombectomy. Of course, there are hematomas and nerve compression. It's not recommended to use closure devices in this artery, so we mostly use compression. Sometimes, if the diameter is okay, we use Proglide to close it. Uh, so you can do a lot of interventions using brachial approach. You can use a kissing stent. You can make a kissing stent if you use both arms. Stiff wires are very helpful here. When you have two stiff wires as a line, you can very easily deliver the stents to the iliac vessels. So if you have strong proximal support, and use braided sheets, it's very, very successful. And subclavian access. This is the last resort access. There are two ways. The first way is open surgery, but we found out that under ultrasound guidance, it is possible to use up to 10 French sheets to the subclavian. This is a case with the intra-aortic balloon pump insertion. The patient was on ECMO, so we could not use the groins because it was busy by a lot of stuff. So we used the doctors from cardiac surgery wanted to convert the ECMO to EABP, so they asked us for help. So we used the subclavian artery. Can I have can I get some help to the movie? Could you please click on the movie? That one, the middle one. Okay, so this is you can see the sheet just below the clavicle, and then the second movie it's working pressure balloon in the aorta.
Can you conclude, please?
Yes. So access roads from radial and brachial approach are well-known alternative to groin approach, especially in difficult groins in patients who requires another, let's say, third access in complicated cases. And everybody should try it if thinking about making if there are difficulties in the access from the groin. Thank you.
Thank you. We move to